Yeah, the little PowerPoint with the little boxes beside it.
Oh, wrong class. There's too many classes. I'm telling you, extra crazy. I'm serious. I feel very scattered right now. Because like you, I've moved. Yeah. My house. Oh, yeah. I actually got my bed. I'm like, I have a couch for a week. Everything's just not. Your brain is not. Exactly.
Turn on iPad. I don't do well with voice activated stuff. I think I'm too stubborn. It just kind of, it's like, what? It doesn't do anything. Okay. So, I'm not a fan of doing PowerPoint because I like to kind of shoot from the hip and but I just don't really ever follow them. But I'm gonna try my best. Well, no, I can't. I'm trying to learn a new thing. We're just gonna kind of fly through chapter 1 because a lot of this is stuff you already know and have heard, either in physics or in anatomy, that kind of thing. We kind of looked at it last week. Remember I said all those names and history. You know, I'll kind of tell you if there's one I think you really need to remember, but if you had like a timeline to go by, maybe you could memorize all this stuff. It's just kind of thrown at you in here. And it's really not that important, but just kind of an idea of the way ultrasound evolved is what we're going to talk about. Okay, don't worry about all those crazy names. Okay. Let's see how I do this. Now I'll put batteries in. Oh, I gotta turn it on. Hey, I can do it. Okay. So the job that you have, most people call you sonographers. The book's just letting you know that you there might be different titles. And this is good if you're doing a job hunt, you know, about a year and a half or so, maybe less than that. I would just search sonographer. You search ultrasonographer, diagnostic medical sonographer, imaging. Look for jobs in go to like a hospital's website. They might put all the jobs under imaging. So do different searching. Because I thought this was good to kind of, you know, keep that in mind. Echo jobs, that's when you're doing ultrasounds of the heart. They're going to be called echocardiography or an echo tech, cardiac ultrasound. So there's different names. So don't do a job search for ultrasonographer and think, well, there's no jobs out there. Okay, widen your search, use different terms. But typically, most people call us sonographers. And you have to be careful too, because if you tell people, has anybody told anybody what they're going to school for and they think they're talking about a court reporter?
Yeah.
Everybody. Yeah. So that's the term they're most familiar with, and their brain goes straight to that. So I'm going to be doing ultrasound, might be a more descriptive term. Okay? Alrighty. Of course, we are allied health professionals. We have specialized education. The majority of people like yourselves being trained now are coming to real, established ultrasound programs like you're enrolled in. Back in the day, people would start out in a different allied health field, like maybe nursing or another type of imaging like x-ray, and then cross-train into ultrasound. But we have taken a few steps ahead And we're recognized as a profession now, and that was part of had to be a legislative type act to be able to get that, right? And it's very important because when your profession is considered a profession by the Department of Labor, then it's going to help, establish a pay grade and everything, okay? And organizations like the SDMS play a big part in that. By being a member of that, it's a voluntary thing, you have to pay dues, but some of those dues go to help pay for lobbyists, people that kind of watch out for bills that might affect our profession, okay? Alrighty. To be completely credentialed, of course, you have to pass the registries, and that's what this whole thing is about, getting you confident and ready to hopefully pass those registries before you graduate, show that you are credentialed. A sonologist is a physician that reads ultrasounds, okay? There aren't as many of those as there are radiologists. Okay, if you work for a hospital, radiologists will be reading your exams. All right, if you work for an OBGYN office, a lot of times it's just that doctor, the OBGYN doctor, that reads the exam. They might send it out to a group that reads, but, okay. Things that we can use it for, anything that's soft tissue, okay? And y'all are already aware of that, right? All the different aspects of it. Musculoskeletal is an up-and-coming imaging modality that a lot of people are, starting to learn. It's mostly on the job, or you can go to a specialized, a 2 or 3 day seminar to learn how to do it if you get some basics behind you. There are a few of our clinical sites that you might rotate to that dabble in musculoskeletal, but then not all of them are going to do everything. There's one site that does, are you okay, Jaleesa?
I put my hand.
Oh, bless your heart. One imaging site in Trustful that they do mostly injections. So people that are having really painful shoulders or knees, as a step before surgery to try to prolong before they have to have surgery, or maybe keep from having surgery, they'll get these injections for pain. So you might see those if you go to Trustful Imaging. UAB Highlands does some more musculoskeletal, but it's probably going to be become a lot more common because of the price of healthcare. There's a new kind of I don't really know what to call it. Somebody mentioned it at our, were y'all here when the supervisor from Shelby came, Susan, last quarter? Remember she mentioned that new thing that's coming out where doctors aren't going to be able to order whatever test they want. It's going to be like a formula. They put in these signs and these symptoms, and some computer software will tell them what they are eligible to order. Okay? So, just the way.
That's weird.
No, it's just the way it's going because of cost of health. Because MRIs are very expensive, CAT scans are very expensive, ultrasound not as much. So it'll be used more often, I believe. That's just kind of the school of thought that it'll be something that coming, but that takes a whole new. It's a different learning curve for us. We have to learn all the muscles and ligaments and everything. And just the shoulder itself, oh my goodness. And all the connections and woo. Anyway, I've looked at it once and I was like, not now. I'm not ready for that. Okay, the advances of ultrasound. There aren't any harmful effects. Remember from physics, we learned that as of now, there are no known bioeffects for ultrasound when it's used in a clinical setting by somebody that's been trained, that understands, you don't just crank up the output power to get a prettier image, right? So, no harmful effects that we know of, no ionizing radiation like you would get from CAT scan or an X-ray, okay? MRI is different. That's a magnet that scrambles up your ions, and when they go back together, somehow it makes the image. So, it doesn't have ionizing radiation either, but it's very expensive. Our equipment is portable. Of course, x-rays are portable most of the time too, but, you know, it's pretty quick. We can run down to the ER, to the OR, wherever we need to. And it's real time, so we don't have to wait for, you know, we see it right then. And we can let somebody know, hey, this patient has a clot, y'all need to address it now. Okay. Alrighty. You're learning that we have multiplanar means we're not just restricted to a specific criteria of orientations. Okay. Take the pancreas. Y'all been kind of remember the first day in lab last week. You learned what way do you have to hold the probe to see the whole pancreas. Remember? Kind of a transverse, but it's oblique, right? Because the pancreas head is inferior to the pancreas tail, so it sits in your body on an oblique angle. So we can look at the whole pancreas. If we were to pull up a CAT scan, you would have to go slice by slice, so you might see the tail first and then get to the head. You wouldn't be able to evaluate it in full length. Now there may be some programs where they can, you know, manipulate and do a 3D image from the CAT scan. I think there's, you know, there's technology, but the traditional view. An X-ray, it's looking at everything at once, kind of all stacked up. All right. So we talked about the cost is less. Contrast agents can be used. It's not approved by the FDA to use them, except for in cardiac in the USA. There probably are some studies going on. In other countries, though, they're using contrast agents. And what that is an injectable or ingestible type of micro bubble. They're tiny, tiny, tiny. And they're encapsulated in some type of chemical that makes them stable where they don't just pop. And they're going to cause enhancement. What is enhancement?
Right, better.
Okay, what did you say?
Brightening.
Brightness, right. So remember the acoustic enhancement posterior to assist makes that tissue brighter. Well, the bubbles will cause a really bright reflection. So say there's a cancer in somebody's liver. This is what we're hoping to be able to get to do here in America, hopefully in the near future if they'll approve it. Cancers are gluttons for blood, okay? They love glucose, so they just suck it up. So they are low resistance vascular beds. So they'll require a lot of blood flow. So if we had a microbubble that showed up really bright white, imagine what it would look like when it got to that mass. The mass would light up like a Christmas tree. Does that make sense? So that's what a contrast agent would do for ultrasound. We're not there yet. Now they do use them in cardiac. So for cardiac, if they suspect a mass going like maybe in one of the ventricles, they could put that contrast agent in and it would fill the whole chamber except for where the mass was. So the whole open chamber would be filled with that contrast enhanced blood, bright white, except for it would outline where the mass was. Okay, so that kind of thing. Alrighty. So it's just telling you some different things that are going on in the field. So different applications. That's what we call those. Modalities or applications. Okay. The role of a sonographer, you know that we work directly with the physician. They order the exam based on the patient's signs, symptoms, lab work, and they have a working diagnosis. What do you think a working diagnosis means?
They're still looking for what's going on. I mean, they think they have an idea, so they do test to.
Right. So they think, well, based on what's going on with this patient, the signs, the symptoms, the labs, everything, I'm thinking they probably have some type of gallbladder issue or maybe a liver disease. Something's going on. They got an idea. They want us to take a look and investigate that. Okay? So we go by the working diagnosis. And another reason it's important to know what the working diagnosis is, we are responsible as sonographers, it is our job to evaluate that working diagnosis against the exam that was ordered. Okay? So if the working diagnosis is, maybe they want us to look for some type of obstructive process in the liver or a disease process in the liver, but a pelvic ultrasound was ordered. Do we just do the pelvic ultrasound and go on? Mm-mm. Okay? You can't think, well, it's not my job, they ordered the wrong test. It is our job, because the position that you hold is based on a specific amount of volume of patients. And when I say volume of patients, it's just not just how many patients you scan, it's how many exams the department is paid for. Okay, so if you're doing 30 exams a day, and you're thinking, we need 2 people, but they're only getting paid for 15, you're not going to get 2 people. Does that make sense? Okay, you might be working like a dog. So it's really, it is up to us to verify that. Plus, you don't want to expose the patient to an unneeded exam. Okay? So we would have to call the physician's office, speak to a nurse, and say, can you check this patient's chart? I'm a little confused by the signs and symptoms based on what was ordered. It could have been a typographical error. Okay? So the nurse will check on it and let you know. Sonographers can take verbal orders and annotate that in the patient's chart. Now, a lot of charts are electronic now, since I've worked in the field and I've never done that. I'm sure you'll get trained on that, okay? It could still be a handwritten chart, just depends on where you go and how advanced they are in technology. But we can take a verbal order, like a nurse can. Now, like say the receptionist cannot take that verbal order, all right? So it is our job to verify that and make sure we get paid for the exam that was done to keep the jobs. Right, follow me? Okay. We do interact with other medical staff, so you need to be prepared for that. Okay, to be able to call and talk to a nurse and explain yourself, explain the exam, or what's going on, what you're questioning. It could be that a patient's in your care, it's an inpatient, they come down and you notice the IV bag is empty. You go, oh, IV bag's empty. Oh well. Okay, you have to stop and call. All right? It's your job when they're in your care to notice stuff like that. Now, are you supposed to change it out or put a new foot? No. You're not supposed to change how much is going in. It's like, well, I'll just slow it down. Just a little bit less. No. We can't do that. Okay? Now, if it's beeping because the battery's low, plug up the little, y'all know what I'm talking about? We can go in the nursing lab and see it. The little machines that are going to control the flow of whatever medicine the patient's getting. If it's beeping at you, a lot of times you have to plug it in because its battery's getting low. You can do that. Patients on oxygen, when they come down, you want to turn off their tank that they transported with and put them on the room oxygen. You have to pay attention before you turn it off. This is what I always try to do. Leave it running. It's okay if it runs out for just a few seconds, okay? If it's set on 2, I don't know if that's 2 pounds per, I don't know what the unit is, but it's a little knob, 1, 2, 3 usually. It's not usually way up. I'd leave that on because by the time, y'all know my brain, squirrel, by the time I got to the wall and turned it on, I'm like, was that a 2 or 3? I'd have to go back and check just to make sure because that's prescribed. You can't give them more or less than what the doctor prescribed them to be on, okay? Oxygen's like a medicine. But you turn that on and you hook them up to the wall, then turn their tank off because you don't want them running out of oxygen on the way up, back to their room. Okay, so things like that we are responsible for. Making sure patients never left by themselves with the bedrolls down. Okay, the bedrolls have to be up if you're not in the room with them. Because what if they fall asleep and roll off the bed? Okay, they could be on meds. If you've ever been on a loopy-headed medicine, you're like, I don't know where I'm at, and the room's spinning. You can't leave their bedroll down. That kind of thing is our job. Okay, we also take a history. You have to talk to the patient. Is anybody gonna have a problem with that, you think? Just, you don't even have to raise your hand. But think to yourself, I don't like talking to people. Am I gonna be able to communicate with this patient and take their history? You know, have you ever had any ultrasounds in the past? Are you gonna be able to explain to them? They say, no, I don't know what this is. Are you gonna be able to explain to them what the test is? You might have to role play with somebody, okay? When you start going to clinical next quarter, you're gonna have to really pay attention to how they interact with patients. Now, does everybody do everything the right way in this world? Okay, don't pick up on bad habits. Sometimes once people get a job and stuff, they'll skip steps or things like that. You know, don't, what's the word I'm trying to think of? Don't, you know, don't just say, well, they didn't do it that way, so I don't really have to follow the rules and do it the right way. You know, don't, what's the word I'm looking for, y'all?
Shortcut.
You follow, take shortcuts, yeah, any of those will work. So, you don't want to say, oh, you're doing that wrong, Miss McCullar said that's wrong. You don't do that. No. Or guest, it's like being a guest in somebody's house. Are you going to walk up to them and say, you know, you're really not putting that thing the right way?
I'm a tell.
Huh?
I'm a tell.
He's going to say, I can't hear him. I'm going to tell. You're going to tell. I'm going to tell them. Yeah. So, we don't do that. Okay, that's a very fast way to get a bad recommendation going forward. They might call and say we don't want them back, but the least when your future potential employer calls for a reference to your clinical site, they're not going to give you a good one. if you question the way they do things. Okay? Just know the right way to do it, and be cognizant, be aware, and don't pick up bad habits. Okay? Because I've had students come back and say, you know, the images they turn in, we would get ripped a new one on our homework if we turn in images like that. If they've settled, that's the word I was looking for. If they've settled for mediocre, that's on them. Okay? I always think when I was scanning, if this was my loved one, this was my daughter, my brother, my mother, what kind of scan would I want them to get? Because when that patient was in the room with me, they were my family member. That's the way I try to look at it. Because I would want them to get the 100% best care I could possibly give. Does that make sense? They're not a number. They're not a gallbladder. I got a gallbladder next. They're somebody's loved one. They matter. They should matter to us too, right? Okay. So if you keep that kind of mindset, you'll always get good patient care. You won't have to wonder, am I doing a good job? And, I mean, don't you want to do a good job and go home at the end of the day feeling like you made a difference in somebody's life? You can't cure that person. You know, you can't fix all of their problems. But if you can make them comfortable, like if you see somebody shivering in the hall, even if they're not your patient, what should you do? Give them a blanket. Go get the warm one from the blanket warmer. Tuck them in. If you can make them feel a little bit better while they're there, then you're going to feel better about the job you're doing. Okay? Anywho, I got to say, yeah. How are we different? We have to communicate with the patient and ask these questions like, okay, say Ms. Farley comes in and all I see on their request is she's having right lower quadrant pain. Okay? Am I just going to do the scan? No. I need to say, you know, tell me what's been going on. What kind of trouble you've been having? You want to hear in their words what's going on. Okay? Because what you're getting on the order is just a little snippet. It's just a little summary. You might find out that she has a history of ovarian cysts. Or maybe she has endometriosis. Okay? You might find out things that are going to help you tailor an exam to fit her needs. You've got to communicate with the patient. You've got to ask them these questions. You need to make sure, have you ever had an ultrasound before? Okay, if she says yes, good, well, you know it's going to be real easy. It shouldn't hurt. You let them know, though. If there is a time where it becomes uncomfortable, just let me know because I can, you know, not push so hard or whatever. You need to talk to them. Let them know that they are in control of the situation. That's called autonomy. You need to make sure that they realize you're getting their consent to do the exam. Don't say, hey, I'm doing an ultrasound on you. You know, just say, your doctor wants us to look at your abdomen. You know, and by doing that, you're letting them know that it's something he wants. If they have an objection, they're free to say it. Right? So what would you do if somebody objects? You do it anyway? That's against the law. Can't do that. If they object, you report that to their doctor and they get to go home or back to their room. We're not, you're not running a prison. It's not like they're subject to what you want to do. Okay? They have to give their consent. But you let them feel like they're in control a little bit by explaining things to it. Make sure they completely understand. Ask them if they have any questions. And they're going to calm down a lot, and it's going to be easier on them and you. Okay? Explain to them, I'm going to put some gel on you, and then I'll use this probe and kind of rub it around. You might have to take some deep breaths, because if you're doing an abdomen, it should take about 15 minutes, that kind of thing. What if you see something? Like, say you see something you think is cancer.
You don't say that.
You don't go,
Don't get
don't go. All right, or like, this is a quandary a lot of techs don't know what to do the first time it happens. Maybe you're scanning somebody in early pregnancy and there's no heartbeat. And you're confident it's a fetal demise. Okay, there's a lot of different roads you can go down. You can go down the road of patient saying, is everything okay? Oh yeah, everything's great. It's good, yeah. That's called a lie, okay? You can go down the road of going, oh, I don't see a heartbeat, your baby's dead. That is called very blunt and abrupt and cruel. People go down both of those roads all the time. You have to decide before you step over the threshold into that situation. You're going to go through the door, okay? It's going to happen. It will. It's not a possibility or even a probability. I can guarantee it will happen. It happens every day. Okay? You got to decide before that happens, what am I going to say? If this is the best out, okay? You know coming into the exam that that's what you're looking for. The doctor thinks the baby's not alive anymore. That's why he sent them to you. They have an idea, all right, that that's what's going on. Give a disclaimer before you start and say, look, the doctor wants us to look around, okay, and just see what we can find, see what's going on, but I'm not a doctor, so I won't be giving you the result. What I'll do is I'll look around and take some images, and then I'll go talk to the doctor, and they'll come back and talk to you. You let them know that up front, because you can imagine, put yourself in the patient's position if you took either one of those roads. If you took the road, oh yeah, things are good, yeah, oh, things are great, and you walk out, then the doctor comes back and says there's no heartbeat, would you not be a little upset? Because you went from, oh my goodness, to everything's okay, back to my baby's dead?
The shock will be greater as well.
Yeah, I mean, that's just cruel, okay? The other one's really cruel because, I mean, do you not realize I'm a real person with feelings and this is my baby that I wanted? You don't just think your baby's dead. And I've had patients tell me about both ways, both roads that people have gone down. So you've got to decide before you go through that door what you're going to have to say something. You can't go, no speak English, or something. You've got to decide. So you can come up with your own, what would you want to hear? So I know you're anxious and you want to know what's going on. I'm going to take some images, but I'm not a doctor. I'm not prepared to give you answers to questions that you have. So I'm going to take the pictures for the doctor and go straight to them and let them look at the images, and then they'll talk to you. And what are they going to say to that? As they keep on and on, say, take a deep breath and hold it in for me. They don't know any different. Okay. We use independent judgment about needing to make adjustments on our scan. So say you're scanning, and you might not have learned this yet. You're just now getting, I know you have, because I'll be teaching it, huh? Okay. We'll start when I can't remember if I teach it. It's either this quarter or next quarter. You'll learn that the portal vein shouldn't be over a certain dimension. If we notice that it looks big, we can't just go, oh, well, that kind of looks big, and keep going. We have to tailor the exam to fit what we're seeing, okay? And if it truly is big, then we add images to the exam. That's what that's talking about. You've got to know what protocol to go to. You've got to know, okay, the doctor's going to want to know the answer to this question because I'm seeing this. They're going to ask me other questions, and I better go ahead and take those pictures. Okay? Huge responsibility on your part to be able to critically think your way through the exam. I always look at old exams if they've had them. If something major is going on, like the patient does have a blood clot, or you see something that looks life-threatening, torsion, something, you let the doctor know right then. Don't let the patient get up. Some facilities, the doctors will want to come in and look at it while you scan, or they might want to scan themselves. That's something else you need to know going in to a new job, is how they do things. Now, there are some facilities that put it all on top of the sonographer like that, telling them about fetal demise. If you know that they're going to say, well, you just tell them. If there's no heartbeat, you let them know. Again, you got to know what you're going to say and how you're going to say it. Okay?
But in that case, isn't it, I thought it's like against the law for us to.
Now, if the doctor told you, I mean, it happens a lot. If the doctor told you they want you to let them know and then they'll talk to them after, I would, okay, a lot of times you're doing a transvaginal at that point. I would let the patient get cleaned up, sit up, get comfortable, and have their loved one in there with them before I said anything. You don't leave them laying exposed in that horribly vulnerable position and say, your baby's dead, or there's no heartbeat. You know what I'm saying? Give them the dignity of at least getting dressed and, you know, where they don't feel like they're spread eagle to the world. You know what I'm saying? You know, that's a horrible position to be in. And, I mean, even if you're doing it transabdominally, would you want to hear that kind of thing laying down and no, I got to get dressed and do it, you know, come on, get dressed first. That's just me. If it was me, I would want to have my husband in there or whoever came with, you know what I'm saying? I don't know. I don't like people telling anybody anything, laying on the bed with gel all over them. Yes, ma'am? Oh, sir? Both of y'all are ma'am.
Nothing personal.
Yes, sir.
I was gonna say, I used to give people HIV results, and one of the hardest things, you know, I didn't know at the time, but you know, when you give those types of results, you really have to get counseling and therapy throughout that, because that's, I mean, continuously telling people that they're HIV positive, and you know, it does something emotionally, you know, it weighs on you emotionally.
As the person, yeah. And that's another aspect of it. This job can be, you have a lot of rewarding things, like I said, when you feel like you've helped somebody, but there are the bad times, you know, the bad things that you see. And even if you're not having to communicate that to the patient, you still know it's there, okay? There could be patients that have cancer already, they're terminal, and with that, they might have a lot of fluid buildup in their abdomen and their peritoneal cavity, so they'll come in periodically, once a week, once every 2 weeks, to have that fluid drained for a therapeutic kind of treatment. Now, it's not going to cure them, but it's going to make them more comfortable. Have you ever had a bloated tummy? How uncomfortable that is? Well, it's not uncommon with that type of ascites caused by cancer to pull 6 liters or more off of somebody. Like a 2-liter Coca-Cola bottle, 3 of those. Okay? So you might see them once a week, every 2 weeks, and then you don't see them anymore. So they've passed. Okay? You build relationships with these people. I had one patient that had liver cancer. She was only 26. It was a very rare kind of cancer. And I was the only one she would let scan her. And I don't know if it was nothing special about me, but I think I was the first one. She knew me. She knew what I was going to do. And I talked her through it, told her everything that was gonna happen, I stayed with her, and, she just, that's all she wanted, okay? Yeah. And it was really sad. I mean, I'm telling you a little more detail because of the heartstrings thing. Because she said that, you know, she was new to this area, her family lived somewhere else, so she was all by herself. I'm thinking, if I was your mama, I don't care, I'd go back to whatever, I'd drop everything, and I would be with you, or come get you, bring you to me. I didn't say that to her, but I'm thinking, what? You know, so you do get emotionally involved. I had a little lady come one time, she was, you know, approaching retirement age, but she wasn't there yet, she was still working. And she had put off coming to the doctor because where she worked, it was just her and another girl that did the same, you know, that job in that department, and they were swamped all the time. And she felt horrible leaving that girl by herself. She said, but I just had to come, and her only symptom was her abdomen was pooching out, and she was kind of uncomfortable, like she had to go to the bathroom all the time, kind of bowel movement, you know, that pressure feeling. And she had ovarian cancer bilaterally, full of ascites, and she never left the hospital. But and it had already metastasized to her liver. So you're thinking, and she's telling me, I just feel so bad I had to take off and she's there by herself. And then she told me about her retirement plans in like 2 years. And I'm thinking, Lord, you ain't never leaving here. And you can't say anything, you know. So you take that kind of stuff home. Like, I had to scan a neonate, you know what that is? A newborn. Okay. So L&D called, actually no, not the L&D, it was the NICU called and said they needed me to verify that the patient had renal agenesis. What's renal?
Kidney.
What's agenesis? Didn't form, right. So the baby had no kidneys. You have to have kidneys to live, okay? Another thing, in utero, the kidneys produce the amniotic fluid. If the amniotic fluid, the fluid the baby's floating around in, isn't there, their lungs don't mature because they'll actually breathe in the fluid, out the fluid. And that bathes the alveoli, and they mature that way so that the baby can breathe once it's here. So even if it had a kidney transplant right then, its lungs weren't developed, so it couldn't breathe, okay? So, you know, when the baby's born, they've got that white stuff on them. Mm-hmm. They had barely cleaned baby up. And mom wasn't even cleaned up. I mean, it was like right after the baby was born. So she's on a stretcher, dad, siblings, aunts, uncles, grandparents. So we're about 20 people in there, and I'm having to scan and verify that there are no kidneys in this baby. Right. And everybody's falling and boo-hooing, okay? Another situation, called down to L&D. A lady was 40 weeks pregnant, came in to be induced, no heartbeat. So I had to go verify that, yes, the baby was dead. So there's a lot of emotional stuff. You do have to take care, like Larry said, of, you want to be compassionate and you want to give the person, like I said, the treatment you'd want your family member to get, but you can't let it rip you apart. Then you wouldn't be human hardly if it didn't bother you a little bit. But just don't let it go, don't go home and dwell on it. If you find that you're the kind of person that it gets to you and that you can't stop thinking about it when you get home, get help. Okay? There's counselors, all kinds of help you can get. Don't just go on that way because you'll lose your mind. Okay? And I wasn't trying to tell y'all this stuff to scare you, but it's just something to be thinking about.
I mean, I'm older than most of these girls, and I've learned over the years that you really have to separate certain things, and you have to leave some things at work, and you have to leave home before you come to work sometimes.
Right.
So sometimes it's hard to separate.
It is very.
I have learned pretty much how to do that. Some people get you on the
Yeah, like for instance, a lot of times, like for me, when I saw, when I went up to the NICU, because you would take your machine up to where the sick babies are in the intensive care unit for newborns. That was the hardest for me. I don't think I could work with neonates, like sick babies, or even kids, like at children's. That's something I just know about myself. I can't do that. Those nurses up there, thank God for them, because somebody's got to do it. I mean, somebody's got to, like when they put the IV in, they bend that little baby's hand all the way back to its arm and they're shoving in and, you know, and I'm like, oh! I watched a little male baby get a catheter and his little wee bled. And I'm like, oh! You know, like, oh my God. Yeah, and I mean, they think them babies up, they, you know, I mean, they're good. They know what they're doing. They're not harming them, and they're doing their job. They're doing what they've got to do to keep them alive, and they're very particular. You don't touch their babies. You know, those nurses are like, what are you gonna do? You know, don't touch that baby.
I have a friend who works in the NICU, and she always referred to them as her babies, not her patient, or I have a patient.
Call them their babies.
No, my baby, this one baby is mine, I have to go and do, you know, she showed me a picture one time of one that was just as big as her hand. She had a tiny, tiny little thing.
It's really hard, I guess, because they have no say-so. You know, it's kind of like.
Right, and it's hard on the nurses too, because I had one tell me one time that she was just, I could tell she wasn't her normal self. Because she was usually, you know, a certain personality. When I went up there, she was just really short and just, it looked like she was about to cry, and she was very upset. There was a baby that, it had anasarca or edema. It's like, their tissues are swollen. And it looked like something out of a movie. I've never, ever seen anything like this. The baby was so swollen up everywhere. Its cheeks were laying on the bed. Its nose, you could barely see that it had little holes because everything was so swollen. It was horrible. Like the fingers looked like little Play-Doh things just stuck on them, puffy. It was awful. And they knew the baby was not going to make it. There's no way medically it could survive. But the parents would not let them turn the baby off of life support. And it had gotten to the nurse because she was like, everything we do causes more suffering to this baby. And she was, at that part had gotten to her that she was doing her job, but everything they did was just prolonging that baby's suffering and making it suffer more and more and more and more and more. And she had just reached her point, you know. So be prepared. I mean, there's a lot more rewarding for us than there is the bad. A lot more, okay? Now, I'm trying to scare y'all. You're not going to be depressed every day. Okay? There is a lot more rewarding, but you got to know, again, that you're going to see things.
You're looking for people are there because there's a problem.
Yeah, right.
You aren't looking to find something wrong with them.
And you're also going to encounter people that are going through anger, because that's one of the things that happens when you're processing a terminal illness. You know, it's denial, and then they get mad, and they might take that out on you. They might not be super nice. But guess what? You have to be. If somebody's just mad and short and just mean, like Oscar the Grouch, do y'all remember him? You can't be Oscar back.
Quiet.
You have to. The best way to diffuse somebody that's mad or upset, they might have had to wait 5 minutes, but to them it might feel like an hour. The way they train you in the hospital, I mean, we just have to go through these little things, is to try to diffuse the situation by not being on the defensive. You know, you would say, Ms. Neal, this is what I'm hearing. I understand, you know, you're telling me that it was too long of a wait, and I apologize. We had, you know, an emergency situation that I was called to, and I truly apologize. We're going to get this done for you as quick as we can and get you back up to your room. Now go, do you not realize that I checked out the ER? Okay? You can't take that tone with them. Okay, diffuse the situation by letting them know that you're hearing what they're saying. Don't be on the defensive. You're the one that gets to go home that night. They don't. Okay? So just kind of keep it in perspective. Don't worry your feelings right here. Doctors are going to be that way sometimes. They will come in like a bulldozer, want to know why you did. Are you stupid? Why did you do that? And da-da-da-da. You can't come up on him either. Okay? I just try to think, okay, yeah, he or she is a real jerk right now. Yeah, their job's a little more high pressure than mine. A So the liability is on them. If somebody dies, guess who gets the garden? Okay? You know? So they have a lot, and they don't just have that one patient. You're dealing with one patient and they're gone. You're done with them. They probably are juggling. Think of how many people they got to go talk to this family, they got to talk to this patient, and remember all the stuff that's going on with that patient. I think, ooh, that's why I'm not a doctor. Squirrel. I wouldn't remember any of it. No, oh yeah. You can't do that as a doctor. You got to know. You have to be on top of it. We were supposed to take pictures of Lane. You can't do stuff like that. You know? Anyway. And that's hard to do too, because most of us, the hair stands up on the back of our neck. If somebody attacks us, we want to attack back, right? It's just a human thing. It's just a survival of the whatevers. Okay. You got to have intellectual curiosity. These are those qualities in sonographer we already, we gave y'all like from day one almost. You've got to be curious. Well, why is that portal vein big? Or, oh, they've got hydra. That's kind of cool. You keep going. No, you got to investigate. You got to be curious. All right. You got to conceptualize. Y'all know now 2 dimensions in 3. Right. You got to think quick. You need to be in good physical health. If you ever leave the job of like working in a radiology department and come to do something like I'm doing, yeah, I gained 20 pounds the first quarter, and it just keeps going up since. Because you're in the hospital, you run. You never stop. I worked 10-hour shifts, so for 10 hours I was run. Sometimes I would get to sit down and take a break, sometimes I wouldn't. Just run. So when I came here and I sit on my hiney most of the time. So don't let anybody ever tell you that the stuff you do at work is not exercise. I'm here to tell you it is.
Yeah.
Independence and initiative. You will not have anybody holding your hand. That's why you've got to learn everything you can here. And when you go to clinicals, everything you can there. Because you're going to be on your own. Now, will you have somebody you can call and double check? Yes, but every stinking patient, you can't call somebody, hey, what do you think? Okay? There comes a time where you've got to be independent. All right? Dedication, all that stuff we talked about. We talked about all that. Okay. We talked about this. Remember, working on terminally ill patients can lead to fatigue and depression. That's worth talking about again, just the part that I said notice it, identify it, get help. You don't want to have a nervous breakdown over this. And if you've never been in that kind of stressful situation, don't think, I'll be fine. You might be able to tell once you go to clinicals if it's going to bother you or if you're going to be okay, and start working through it even then. Most people are pretty much okay, but this is, I've seen stuff like our kind of job take its toll on people, where they just get into a funk, just like a melancholy kind of, they're always down. So that's the kind of thing you want to look out for. But I'm sure you'll probably be fine. Just keep an eye on it. Just like with your physical stuff. Like if you notice you go home at the end of the day and your scanning arm is always hurting, and it's kind of getting worse, and then you start aching, you're like, oh, I'm having these little twinges of pain. Those are called spasms. You need to get help. Go get a massage. Maybe in between patients, do those stretches. Just stretch out and take a break. You can have fatigue with your eyes. The 20-20-20 rule. Every 20 minutes, look away from that ultrasound screen. Look at something else for at least 20 seconds that's 20 feet away. Okay? If you don't, you can get that mental fatigue. If you know you need corrective lenses, don't scan without them. You will hurt yourself. Okay? I could never work in contacts. I don't know, something about maybe just being so concentrated on the screen. Maybe I didn't blink enough. I don't know what it was, but my eyes were so dry. But to get the contact out was like pain. because it just would dry up so bad. It might be the kind of contact, I don't know, but I turned to glasses. I'm like, I can't do contacts at work. Now I don't do them at all. I like glasses better. But if you get an eye exam every year, you know, take care of your eyes. Your eyes and your hand, your arm, you know, and your feet. Wear really good shoes with good support. That's your money makers, right? Your money makers are good eyes, a good strong arm, and feet that can get you from place to place. Those are your money makers, okay? Your brain. You know.
Oh, yeah.
So that's what all this is talking about, covered in here. Job market, it's been really good lately. If you're willing to move, jobs are everywhere. Okay? And you can do things other than just being a tech. You can get your degree and do like Miss Van Hood, be a program director. Lord help her. All of that job. Okay? The resources, they're listed. It's good to be, like, I think I mentioned this to y'all, if you join the SDMS, you get these journals every 2 months, and they're really good. The AIUM is good too, but it's more for doctors and maybe physicists. It's kind of written on their level. Their journals are a little over my head. I get more from the SDMS. Because I think it's the way that there's some in the bookshelf in the lab that you can look at. They'll tell you to start out the goal here. This is why we're doing this article, is to talk about blah, 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 blah. And kind of give you a little summary. And then it gives you a little bit of the statistical stuff, how they did the study and how they compared things. And it just gives a breakdown at the end. So this is what it really means to a sonographer. Whereas the AIUM, it's all really good, relevant stuff, but it's a lot more of that statistical ratios. And I'm just not a statistical-minded person. Some people that really speaks to me, I'm like, can you break that down? What does that mean to me? So, you know, the ARDMS, American Registry for Diagnostic Medical Sonography. That's one of the places you can get a credential from, and that's, you know, usually here, that's what we do is we prepare you to take the SPI and a modality, and the school will pay for it, those two. But you can also go through the ARRT, the radiology accreditors, or the people who are credentialers. You can take one test, and it's all one ball of wax, the physics, abdomen, and OB. So if you get an RT, it would be, this is what the credential would look like. RT, and in parentheses would be an S. Okay? I guess the R stands for Radiologic Technologist Sonography. Maybe that's what it stands for. Or Registered Technologist, I'm not sure what their R means. Ours is, like behind my name is RDMS, Registered Diagnostic Medical Sonographer. I got my credentials through the American Registry for Diagnostic Medical Sonography. Okay? You can get vascular through them. It would be RVT, is it RDMS, Registered Vascular Technologist. You can go through Cardiovascular Credentialing International. I don't know why I'm so tongue-tied today. CCI. And that would be RVS, Registered Vascular Sonographer. So you can get credentials from more places. Okay? I know that the ARRT one, it is one test, but it's 6 hours long.
But is it cheaper if that's what you're...
$450. Last time I checked, I believe it's $450. But it's the same, because the SPI is $200.
Yeah, that's what
A
I was
modality is
thinking.
$250, it's still $450. It's either $450 or $400, it's real close to that. But you want to get credentialed, okay? So. JRC-DMS, that too gave the recommendation for this program to become accredited, an accredited program, so that you could take these exams. Yes?
Do you have to get like, credits, it's continuing education every, like 24 for 2 years or something?
They could change by the time, you never know, by the time, but it's usually, I'm not sure about if you get this, RT.
For my RT, we have to get 24 every 2 years.
The way, if you go through ARDMS, the way it works, you'll be assigned a 3-year period. So say somebody gets registered in 2015. Their period would be 16, 17, and 18. They have to get 30 CMEs, continuing medical education credits, okay? Each time you get a credential, they award you 15.
See, with RT, if I pass, you know, the registry here, then that counts for the whole 24 for RT.
Good.
Right now.
Yeah.
That might change.
But yeah, you have to get that every 3 years. It's an honor system, but I get most of mine through the SDMS. You can get CMEs through them, and they're linked with ARDMS, so it keeps the CME bank for you. It tells you how many you need.
That's what the RT does.
You can get them from outside sources, but you have to keep them in case you're audited. They might, used to we could download them. They've kind of gone back and forth. I never know. I just do it through them, and well, they can keep up with it. I don't have to worry about it. But yeah, you have to do that, and you have to pay dues every year. If you don't get your CMEs and you don't pay your dues, you lose your credentials. You have to start all over, taking the test again and all that.
One time when I had the kids and I didn't get enough CEUs, and then they doubled it. So I had to get like 56 in that time, and I never messed up that again.
Yeah, that's a lot. Yeah. You can do, in those journals I was telling you about, if you're an SDMS member, you can get wait a minute. I think there's 2 CME opportunities in every journal, so that would be 12 a year. So paying your membership. Now, once you're not a student, once you graduate, the membership fee is much more. I think for y'all now it's like $40 for 1 year. But like for me, it's $160 to be a member. The school pays, you know, my employer pays for it, so that's good. I just got to turn it in. Mine expired in July, I think. Okay. Any questions about any of this stuff? I thought we were going to fly through it. See if I go straight by that. Okay. History. Okay, this is where all these names came in. I mean, long time ago. People started investigating and realizing that sound is energy, okay, because it was causing things to happen through what it was traveling through. I mean, when the media oscillates and vibrates, just like if you had that, you know, we talked about the car pulling up beside you at the red light, and they have their bass really deep and turned up, and you feel it boom, 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 boom in your chest. Yeah, so it was obvious that sound, you know, was changing stuff and had energy. So people were always curious about it and looking at it, like Da Vinci and Galileo. So that's, you know, they're just trying to tell you that we've always known that sound had energy in it. Okay? Newton did some work on how fast speed that sound is through air. And then you had all these other people do experiments with like bats, and you're trying to figure out how bats realize where those little mosquitoes were when they were flying through the air using radar. Okay. Curie, do y'all remember anything about that name? Remember talking about Curie? Remember the Curie brothers and the Curie point? Okay. They discovered the piezoelectricity effect. And when you apply pressure to these crystals, then electricity can be produced. So they realized that that sound wave coming back applies that pressure, so we get the electrical voltage out of it. Okay, Doppler, Christian Doppler. Of course, the Doppler effect is named after him. He's got a lot of stuff named after him, like Doppler they use in the weather radar and stuff. It's the same kind of thing. But there's a change in frequency when, basically, if the source is directed at something that's moving, like these frequencies from sound or wind, if it's moving away, then when that frequency bounces back, it will be a lower frequency than it started out. Okay? If whatever you're sampling is moving towards the source, the frequency that comes back is higher. He's the one who figured all this out. Okay? So Doppler, you'll see. Curie, you know. Okay, Lord Rayleigh, wrote The Theory of Sound. A lot of, what we know about sound came from him. Okay, so what happened? Sonar, the Navy, started to use sonar, like with their submarines, for navigation, to look for other submarines, like maybe the enemy, that kind of thing. They're very low or extremely high frequencies that were used so that nobody could hear it, okay? Ultrasonic or infrasonic. And they realized when they were using these sound waves and started experimenting with them, that they were killing some of the fish. As if the fish swam through that sound beam, they would die. They're like, this has adverse biological effects. Okay? So they're like, maybe somebody needs to study that. All right? Let's see. Trying to get to real time. Okay, but one thing, you don't remember the name, but one of the first types of ultrasound used on humans, there's a picture of it. Look at figure 1.1 on page 6, the immersion tank. Remember us talking about how sound doesn't lose any of its energy when it's getting to go through water, right? It doesn't pay that attenuation coefficient. So they put the patient down in a water bath. It'd have to be a relatively healthy patient to see this. But the scanner would go around them, okay, through the water. That's kind of a picture of that. See the little stick down in the water? It's going to go around him. All right. There's another type of a water path in 1-2. It's kind of hard to see. I think of it like a big giant Ziploc bag full of water touching the patient, and then the sound goes through it into the patient. So we've come a long way. Now also look at this neonatal head, figure 1-4. That was a static image that they did in the baby's head. See how the baby's laying in that kind of a water bed? With the water up around its little head? So that's what they had to use to scan. And these were static images, y'all. These weren't real time. They were, you just let it do its thing and sit there and wait, and wait, and wait, and then you get a picture. And see how it's white on black? Or wait a minute, black on white. Sorry, I said it backwards. It's black on white. Our images are whites and grays over black. It's a little bit different. Okay. So there he is. I should just click one more time. All right. It was actually a B-52 gun turret tank that he's sitting in. I wonder how they got his legs up there. That's his legs? Yeah, but how's the water staying in it? I don't know. Oh, he's up against the side of it. I see now. But still, has it not? I don't know. Maybe it's plastic. Maybe that part's plastic and he gets up. Yeah, but it's just one-sided. It didn't go the whole way. It just kind of goes around like this. So he's up against the side, so it'll do like a half moon. I guess you'd have to turn this way to do the other side.
Yeah.
Okay? It does. Alrighty. So we've come a long way, right? Echo was started back in 1954. That's when they started using M mode. You remember M mode, the motion mode? Okay. Ian Donald, he's like the father of OB ultrasound. That's a name that you might see. Okay, Ian Donald. In 57, he used an early contact compound scanner. So this is the first one that, or these contact compound scanners were the first ones that actually touched the patient, okay? And this book doesn't have a picture of it. I think it's your physics book that has a picture of it. But it was on an arm, like a, you call it a matriculating arm that can move, bend, different elbows on it. But the patient would be laying there, and you'd have to take it and pull it across. You still didn't see anything. You have to wait until the picture comes up. seems like it was a picture of a baby or something in y'all's physics book. Kind of an arch, a little jagged arch picture. But anyway. There was that other water bath path. Alrighty. Grayscale imaging, 1972. Grayscale is that where we change from the static black over white, real contrasting, to the grayscale, meaning instead of just a brightness mode, each returning echo strength would be displayed by a different shade of gray. So really strong echoes were on what end of the scale, white or black? White end. Really weak echoes to no echo is on the black end of the scale. So as the echo gets stronger, it gets assigned a little bit brighter shade of gray, okay? So we're looking at, say, a liver, and we say that it has a mid-level gray, homogeneous appearance if it's normal. So when we're imaging a liver, we don't want to make it bright white if it's not bright white. You're like, well, how do I know where to adjust it? Could I not make a liver that's echogenic gray by turning down the overall? Well, yes, you can. But what do you think? Just think about the anatomy you know so far, the things that you've looked at. What's something that would be a control, something you could check against, that you know what the color is? If the patient's alive, this part is going to have this specific color.
The gallbladder.
Gallbladder should be black, but what else would y'all say? The pancreas can vary. I'm thinking about vessels, okay? Like say the hepatic, obviously it can kind of be fuzzy, but yes, it should be black. Usually you can find a vessel in the liver that you can see pretty well. It should be black, right? So say you put the probe down and you see in the left lobe a vessel, a left hepatic maybe, and it's all really, the whole liver's bright, and even that hepatic has echoes in it. What would that tell you? Turn down the overall gain. Let the vessel be your control. If the vessel's black, then examine some other stuff. Like you said, the gallbladder, take a look at it. Like if the gallbladder is the first thing you look at, though, you might think, oh, the patient's got sludge if there's stuff in there. Start with maybe a vessel, then look at the gallbladder, and use those as your control. So if they're looking normal, then your gain's probably right. Does that make sense? So fix the overall gain first, get it where it needs to be, and then just adjust your TGCs to make it uniform. Make sense? Okay. But we have that ability now. What's really great is that if there's a subtle difference, if we're using enough grayscale options, if we have a big enough grayscale, we'll see that subtle change. Like maybe an area in the liver where it's a little bit darker than the rest of the liver. Okay? Or it's a little bit brighter than the rest of the liver. That's what we're looking for. The scary stuff, cancers, are usually echogenic. No, excuse me. The liver is echogenic compared to them. Okay? So, a liver cancer might just be a little bit darker than the normal liver, is what I was trying to say. Okay? Same thing with kidneys. Alright? There's that thing. Alright. See, it jumps back and forth. They just talked about grayscale, and then they go back to the V scanner. And that's like that picture where it's white on black. Or the one in figure 1.4, black on white. Alright, they got to where they could produce images, 15 images per second, which was a big leap. That's still not real time. Alrighty. In 73, Griffith and Henry produced a mechanical oscillating real-time scanning device. But remember the mechanical probe? Inside was one disc and it oscillated back and forth so it shoots sound beams. They were able to figure out how to do it fast enough that we got a real-time image. So that was a huge leap. To scan something real-time, it's just like when y'all were trying to learn ultrasound images, you look at these little pictures and you're like, okay. But once you went into the lab, didn't it make a lot more sense to see it live. The real time is a huge jump. Then phased array scanning. Okay? You know, I can remember some of that guy's name. But after real time, we got off the mechanical oscillating came to phased array. And what can we do with phased array? Why do we like phased array so much? You may remember? Electronic steering and
Different depth.
different focal points, right? We can pick where we want the focus to be. We can add them, we can take them away, we can move it. Huge to our image quality, okay? So we went from mechanical oscillating, real time, well, static, water bath, and then the compound scanner where you actually drug it in contact on the patient. And then we went to the mechanical oscillating real time, and then linear array real time. That's kind of what I wanted y'all to see, the progression, not so much all these people's names. Okay? The Doppler came in. Actually, in Japan they're using it 55, so it's jumping back and forth a little bit. But the Doppler was not on every machine, even when I started scanning. Some hospitals still had machines that did not have Doppler. They didn't have cine loop. You had to freeze, and what you froze that was it. Okay? So things have evolved now. Y'all just don't know how good you got it. Okay? We've gone from like a horse and buggy to a Mustang. We really jumped big. Alrighty. So it kind of looks like, just by that timeline, in the decade between like 63 and 75, decade plus a couple of years, that's when Doppler really got, you know, took leaps and bounds. Okay. In 91, they started using a matrix array scanner. And if y'all remember the matrix array, instead of just having the elements like this lined up inside the probe, they subdiced them that way too. And that way, not only could you control the aperture or how wide the sound beam started out, you could also control the elevation plane as well. Do y'all remember us talking about that? So that we don't look like, look at a gallbladder. If you look at a gallbladder, the cystic structures, and see adjacent structures superimposed inside of them, slice thickness artifacts is what they're called. We talked about how you could scan a gallbladder in long, and if the sound beam had a poor elevation plane, so you're scanning this way. Okay, so you're seeing anterior to posterior, superior to inferior on your image. The duodenum plane over here. Well, if the sound beam is wide in that third dimension, which it has a third dimension, your cystic structure being the gallbladder could have duodenum superimposed into it. So it could look like stuff was in the gallbladder. It's not going to affect solid structures like the liver, because liver here is liver here, liver everywhere is liver, right? Your gallbladder's cystic, if something solid's beside it, all the machine knows, hey, there's an echo that came back from that depth, it'll put it there, even though it was from a plane adjacent to what you were actually looking at. Okay, so that's what this is helping get rid of, the matrix. This is the physics, so we wouldn't go through a lot of it. I do want you to remember, what do we call that? A cycle. Remember, one cycle?
Right.
One complete cycle is made up of one
Compression,
and one
refraction.
Right. So that's one oscillation of one of the acoustic variables. You may remember what the acoustic variables are. Pressure, density, and distance. So of the medium, the sound is energy. We call it a mechanical energy because it changes those three things in the medium. because the medium is wiggling, oscillating back and forth with changes of pressure, density, and particle motion all at the same time. And that's just how we draw that change. So the flat line was that normal for the acoustic variable. Then you have the compression, is when it's compressed and pressure's increased. It goes back through normal and it goes to the decrease, same amount, and back to normal. It's one oscillation. Okay? Okay. This is a better depiction. We draw it like this because it takes forever to draw it like that. But since they did, we will look at it. This is representative of the little particles as the energy is moving through them. This will be like their normal. So the sound just went through. You see them pulling back away, going back, and this is during compression when they're all pushed together, and they pull back away, and they're pushed together, and they pull back away. So that's a good way to look at it. It's just really hard to draw. Does that make sense to everybody? That's really what's happening. It's like if we were all lined up in a row, not touching, but really close to each other, and somebody pushed us, you know, I would go forward into the next person, but would I stay there? No, or come back. It would do that the whole way, and we just kind of, I think of weebles. Remember the little weebles wobble, but they don't fall down? Yeah, little weebles. Okay. We didn't have a break. Y'all need a break? I just talked like that. I'm so sorry. You say yes or no? Okay, yes. All right. Y'all can take a break.
Well, I mean, you're free to go.
Get busy.
Well, I mean,
No, I was explaining, like, I recorded Miss Abel's, but it's still downloading. So now I'm using YouTube. I had to get, like, find the Wi-Fi for here to use the YouTube to record it.
Bless your heart.
Yeah.
I mean, because so Miss Abel's and I can't even think of what it is.
There you go.
And so it's downloaded.
Well, now, yeah, for this class.
What's the name?
I'm gonna put it on the DMS when yeah. Well, I'm sorry.
Oh, no, just that that's still downloading, huh?
Yeah, it's still downloading. It's literally still downloading.
That is so crazy.
It has like 6,000 more minutes for that one.
Oh my gosh. That's
Okay.
awful nice of you to do that.
Well, it's better than, mine. Yeah. Mine.
Yeah, it's better than mine. It's nice to water.
All right.
No, that's for
I thought
everybody.
maybe she said something. Because it sometimes doesn't matter if I'm here or not.
It's a really good review though, and it's on your listening sheet. The little things I hang out with the blocks to the side, like you got them. So each of these slides are on it.
Well, those aren't, we are stopped at, history, where it had Duke University.
Okay, I thought I'd put all this in there. I'll just put this on to put it on your portal.
What Miss Van do, I know when she came in and when we talked to her when we first met her, she was saying something about like the review question that be on the register.
Yeah, what we'll do is, we want to look through some questions and talk about, how do you decipher what this question is really asking you? And we'll pick the options A, B, C, D, or E. It'll be a registry type question, and we'll read through them and pick the one that's the best and just discuss how we go about working on those kind. And there'll be some of those type questions on each test, just to get y'all ready for them. Yeah, this is the whole thing. Yeah. So I'll put it on, I didn't realize I'll let y'all this on. Yeah, I'll put this one on your portal. I'll just do it. Let me go ahead and do that while I'm thinking about it. Let's see, is everybody here? I'm missing some people. Did everybody sign in? Yeah, there's some people that haven't signed in yet. Better wait. Number 3, yeah. Yeah, it'll be due the 19th. And these are big questions. Yeah, she wanted us to go give you the PowerPoint, and then I left some, yeah, and I just took some letters out, or took some words out, and y'all can go back and fill them in as I was talking about them, but she just told y'all to have them as we were going.
Will you give us the chapter 3 today, or will that be?
We're not going over chapter 3 until next week. Yeah, go ahead and read ahead.
Well, no, you gave it this one. So I'll go back and give you chapter 3.
I like for the read ahead.
I don't even know if we'll get to chapter 2 today.
Oh, yeah. But I've never seen the list. Yeah. Things can change. And then I'm just like, what's maybe? Not much. One of my nieces, she can sit down and eat a whole head of cabbage raw by herself, and she'll eat a whole packet of her baby. Yeah, and that doesn't have 30 left. No, it's not. Sorry, yeah. It's like celery. Our homework, we do it, our, there's.
On your Texas, I will go through them all and review them one by one, and put comments, and it'll email you the worksheet.
Okay.
If you don't get the worksheet, you can always go on to Texas and look at it. It'll have my policies on it. Not your Texas, I meant for you, Mindy. Sorry. I'm sorry.
I got you.
I meant for you.
So just before the quiz that we did, you gotta go full.
That's what If you've already got, as soon as you get it done, you're ready to put it on the preliminary. Someone's got a great son today. There's a lot.
I mean, you need to limit
No, it has to be on frame.
And since you challenge your. That's what I was wondering.
I don't know what I was thinking. I was not adjusting. I didn't adjust at all.
Just Google it, but if you
I'm very interested, but it is, I want to do it again.
You get credit for this first one. Just take the comment and then improve on it. Next one, I'll start counting them off.
I don't have like, have an idea of.
I literally just forgot
What I don't know what to go through.
Okay.
You know?
It like messed up the first time I got it. Like, you gonna text me, like, your computer's messing up right now. Well, I haven't gotten it yet. I still have to take that.
The problem.
We have like a bunch of options to do it, and there's like, I have a street down from these. Yeah. That's what my head says.
We all came Friday. I got a phone call, but I couldn't. I noticed you weren't here.
I don't know, there's so many things.
They're allergic to it.
Thank you.
And they're just, thank you, they're just now started away from them.
Okay, I need everybody to kind of, look up here a second. There's two people that didn't sign in. Okay, it's up here. Yeah, be sure to sign in, because you won't be counted present if you don't sign in.
You get my email, Mr. McCullar?
Monday.
Then I woke up.
Share.
I had bad allergies on my life, you know, airborne. Hay fever. But never been.
Ice cream.
The images are expired.
My memory.
My dad didn't.
Yeah.
There's some like I want to get rid of.
And I know.
Okay, everybody, 1 second, please. I put on here the 2 PowerPoints, chapter 1, chapter 2, and then also I put those images. Even if you've done your assignment, if you want to go back and practice, hopefully you do. So we'll open up slowly. Okay. Those images I told you to look at, let me turn the light off, just to kind of see what I'm looking for. And they're all pretty good except for, oops, for slowness. This one, you know, that's got, tell me what's wrong with it.
Too much
Yeah,
shadow.
way too much depth.
Okay.
Okay. And I would like it to be centered and cleaner. But this was to represent,
Already low.
actually, this is just the left lobe image. They kind of cut that off. I think there is another one called A. Yeah, there's called A lobe. They actually cut too much off on this one. But these are the best ones I could find. You could get rid of some depth here. I just got them off the internet.
Prettier than mine.
I know.
I mean, it's like, it does not look
I
like
didn't
that,
know
but I
how
have
to
to
do
do
it.
it.
It's just something to go back and review and the anatomy and stuff. Okay. Not perfection, it's just the best I could find off the internet. Okay, and then also that's under other. And I just went and put it under study guide because it really didn't fit it under syllabus. Those two, the first two PowerPoints in full. Okay, here comes the bright light.
You're not having testing here until the future?
No, we do. I just didn't know where they would fall.
Okay.
So, I didn't put them on there because again, this is the first time I've taught it in ages, and then I didn't know how big every other day, not every other day, but,
Every other week, every next week.
yeah, I just didn't know how it would fall. Enough information.
Next week,
Yeah.
I probably won't give you one next week. Bright light, bright light.
Yeah, just give us, you know, like a advance of your one.
I definitely look at it. At least a week. I won't like see you the day before it happens. Alright, now I need to go back to here. Over there. Pull that second one out. I had it pulled out and I don't know where it's going. Oh, there it is. It's still there. No, that's chapter 1. I need to. Okay, so, we've got all of 8 minutes.
Yeah.
Woo-hoo! Okay, when they're doing a health assessment, you're trying to look for those signs and symptoms. You're going to be, you know, interviewing the patient, but also you're going to be looking. Like if a patient walks in, if you notice their whites of their eyes are yellow, then you can observe jaundice. Okay? Maybe if their leg is swollen and they're complaining of it being tender, but you're making observations as well as taking signs and symptoms from them. Okay? So objective data versus subjective. Objective would be those observables, okay? Or even if you took their blood pressure and it's definitely high. You can see that. Subjective is, oh, it hurts right here. You're just taking their word for it. Because some people can have pain and it not show on their face, and they really be in pain. You know, but they're not like, that kind of thing, okay? I'm really hurting. Not be, you know, the worst face they make. And then there's other people that, you know, they get a little paper cut and look like they're been run over by a car or something, okay? You never really know for sure. But, a word to the wise, if a patient says they are hurting, take them for their word that they're hurting, okay? The reason I say that is like, I've scanned people with ovarian cysts that are 5 centimeters, you know, pretty big cyst, and they don't even know it's there. It hasn't bothered them, okay? Then I've scanned people with a 2 centimeter cyst that shouldn't even, definitely within a range of normal as far as size, and it's really causing them pain. Don't take for granted that they're not hurting. Are you following me? I've heard texts say, there's no way that could have hurt her that bad, it was only 2 centimeters. How do you know? Maybe there's scar tissue around where that cyst is, and it's pulling against the nerve. You never know. I've had the cyst that's small that hurts a lot, and I've had the one that's large that barely hurt me at all. And I know because I'm thinking myself. I can see them. Like, that's a little prickle, but it sure is hurting. You never know. So please don't be one of those people that, now there are people that exaggerate, but give the people that are really hurting the benefit of the doubt. They don't, so they really don't look that sick. You follow me? Okay? That's one of my pet peeves. I just really don't like that. Okay. So we want to gather that subjective data to see if we can't help figure out what we need to be looking for. It is important. Don't take for granted what the patient's saying. We always want to introduce ourselves to the patient, and you have to verify their name. This is huge. Okay? I've had people get up out of a waiting room. I call for Mr. Johnson. And, okay, Mr. Johnson, my name is, and I say their name again. I used to try to say it at least twice. And get back, and then I ask them their birthday. You don't ask them somebody's birthday in front of the rest of the waiting room. Wait till you're walking back and it comes in private. And the birthday doesn't match. And come find out, this is Mr. Smith. He just got up and came with me. Okay? You gotta verify that you got the right patient. That's why you want to rely on the birthday. Can you verify your birthday for me? And that way, you know, it's pretty, even if they are hard of hearing, they're going to give you their own birthday and you can compare. All right, and there could be maybe two Mr. Smiths sitting there. And maybe, you know, the other one had gone to the bathroom, the one you really needed. You got to verify. If it's an inpatient, they'll have an armband, and you have to verify. Look at their armband and ask them, you know, still ask them their birthday, because maybe they put the wrong armband on them. I don't know. But that is your job. Don't assume anything, okay? You let them know. This is what everything will be kept confidential. I've never really ever said that to a patient, but what I was talking about, like, don't start talking to them about their symptoms and stuff walking down the hall. That's kind of a given. If you wait to even ask them their birthday till you're in your department, they'll realize, you know, that you're going to keep stuff confidential. I've never really told them that, but it's probably not a bad practice. But there's some saying, don't say, as you're walking to the room, okay, what's been going on? They don't want to talk about that out in front of everybody. Well, I have this rash. No. You don't want to talk about that in front of everybody. And be sure they speak English. I had a patient trying to get her fill her bladder up for a repro and told her to drink, gave her the prep, gave her the glass of water. She sat there and drank it. I went to check her, empty as she could be. I'm thinking, gosh, she must be dehydrated. Because every time I talked to her, she'd say, yes, yes, yes. I said, don't please, yes. I mean, 3 hours later, I'm thinking, what is wrong with this lady? Have you gone to the bathroom? Yes. Do you understand what I'm saying? Yes. No, I don't think so. So I called the funny thing is I called the doctor's office. I said, I've realized that there's a communication barrier. The next time y'all send somebody here that can't speak English, that would be a good thing to put on the request, because she said yes to everything I've said to her, and I didn't realize. Can someone come up and communicate? Sorry, I didn't turn it off. Can someone come up and communicate with her the prep? Because, you know, the doctor came up. I didn't know it was him either. But anyway, that was really nice. He came and talked to her. You know, she said, oh, I thought you wanted me to drink a lot. Anyway, so be sure they speak English, all right? If they don't, there's usually a translator. Most hospitals now have, you know, translators available to either come to you or talk to them on the phone, that kind of thing. Always use their last name, okay? Now, if they tell you, oh, just call me Brenda, that's fine. But address them by their last name and be respectful. Even when we get patients here, once y'all get to OB lab, I know we're done. But, and this is a more casual atmosphere, but you're practicing for the real world. You always address people by their last name. Now, some places don't do that, but that's what we're going to do, all right? Now, if you get to a site that they, you know, don't do that and they want you to call them by their first name, do what they want you to do, but that's the respectful thing to do, all right? And that's a little Sorry. And please.
McCullar. Now, this homework, I was so confused.
Okay, I went over it and you weren't here yet, so let me explain it to you.
Okay.
Where it says HA,